mind to life. Inner circles here where voices thrive. Turn on your screens, let the magic unfold. Listening and healing as stories are told. Come one, come all, this is your time. No topics too tough, just heed the call. From mental health woes to justice we seek. Together we rise for the strong and the meek. A safe space for all, let's lift every voice. Inner Circle podcast where hearts unite. Sharing our truths, bringing hope to the light. Community strong, we're never alone. Together as one, we've created a home. With laughter and love, we break down the walls. No topics too tough, just heed the call. From mental health woes to justice we seek. Together we rise for the strong and the meek. A safe space for all, let's lift every voice. So join the conversation, let's set the tone. Inner Circle podcast where love is well known. Inner Circle podcast where hearts unite. Sharing our truths bring.
Good evening, everyone, and welcome to another powerful episode of the Inner Circle podcast. I'm your host, Abe Chomilo, and today is Wednesday, May 28th, and we have a very special guest in studio with us that's going to talk to us about Medicaid, about, Minnesota Department of Health. And his name is Dr. Nathan Chomilo. Again, it's going to be a great conversation. Medicaid has been in the news quite a bit lately, with federal changes, state budgets debate and things like that. So tonight, normally it's our business segment, but we have a special guest. So we expect this to be a great conversation. So Dr. Nathan, thanks so much for joining us tonight, and welcome to the Inner Circle podcast.
Yeah, thank you for having me.
Yeah. So, folks, before we begin, welcome, Miss B. Thanks for joining us.
Good evening, everyone. It's your girl, Miss B. It's Business and Finance Wednesday, but we're taking a little detour today. Welcome.
That's good. So, folks, you can join the conversation by calling our number 952-594-5154, or you can put a comment in the chat if you have a question for Dr. Nathan. And also, there is a growing community. Please subscribe to our YouTube channel, follow us on Facebook or wherever you get your podcasts, Apple Podcasts, Spotify, LinkedIn, and X. So getting right into it, Dr. Nathan Chomilo, can you tell us a little bit about yourself and your background?
Yeah, thanks for having me again, Abe. So I am a pediatrician and internist, and have been serving as the Medicaid Medical Director for 5 years. But I will admit that, about 6 years ago, if you would have asked me what you wanted to do, being a state Medicaid Medical Director wasn't really on my list. Okay. So I grew up wanting to go into medicine. I was born here in the Twin Cities, but my parents were born in Cameroon. Okay. My dad is a pharmacist, my mom is a nurse, and so kind of growing up, I was always around healthcare, and I was always seeing how whenever we'd be out in community events, people would come up to them and ask them questions about, how to navigate their health. Sometimes it was just like, what's this rash on my skin? But sometimes it was like, how do I get these medications? What's the right doctor to go to? And they were really able to help folks out. And so I was always interested in that. I was interested in learning about the body and how the body works and how it doesn't work and how we can help people feel better. And I really like working with kids. And so, I played soccer growing up and ended up then going into coaching some soccer myself. I was a camp counselor. And so I really loved just working with kids and helping kids thrive and grow as well. And so when I went into medical school, those are kind of the most enduring interests and things I pursued in my training initially.
Okay.
And then while I was in medical school, a couple of different things. I, first learned about social determinants of health and how, our health is so much more than what happens when we go to the doctor or when we go to the hospital. It really is greatly impacted, sometimes more impacted by the food we eat, the ability to rest, the ability to have education and have a job, breathe clean air, drink clean water, and have parents, family, community around us that helps us grow and thrive.
Sure.
And so wanting to be a healer, I really start to learn more about and read things outside of just my textbooks about how the body works, but what are the
Sure.
systems we've
Okay.
set up to help
Okay.
folks be healthy and access health. And that really ended up kind of setting the stage for a lot of my work, outside the clinic, as how, I saw my ability to, not only help people who showed up to my clinic or,
Sure.
I saw in the hospital, but be someone who could, somewhat like my parents, right, help people navigate the system, help
Yeah.
and then with my additional training, help improve the system, hopefully, so that it kind of is more accessible. It's more appropriate. It understands the value of those social determinants of health. And so I ended up getting dual certification in both pediatrics, so taking care of kids,
Okay.
and internal medicine, so double
Okay.
board certified. And then from there, eventually my work around health equity and health justice led me to want to learn more about Medicaid and learn how the state helps provide folks health care and pays providers, and then providers make changes in how they deliver care based on how they get paid, right?
Okay.
And so wanting to really understand that how our healthcare system is driven, by capitalism, like so much other parts of our world, and how we could actually use that to better align these goals
Okay.
of improving care, improving access for everyone in our community, in particular Black and Brown communities who, the way this healthcare is set up in this country has
Yeah.
been really along lines of race and class. And so wanting to, bring that to light and figure out ways we could do it better.
Okay. So is that what was that an inspiration of you going into policy making, especially going to work for the state? I mean, what was that? What was that transition like, right? Leaving the exam room and going to state government?
Great question. Yeah. So for me, it really started, I first learned about this program called Reach Out and Read when I was in my internship. And it's a program where people might have experienced it because we've helped grow it here in Minnesota.
Okay.
And it's around the country as well. You go to your child's checkup to see the doctor when they're young, and the doctor gives your child a book. And talks with you about how reading is important. And for me, like, I was a real avid reader. I remember just reading, getting all these like awards in like elementary school for how much I would read and love to read. And so I really identified a lot of my academic or my school success with my love of reading.
Okay.
And literacy itself, being able to understand what the doctor or nurses are telling you, being able to follow those instructions to take care of your health. That's a social determinant of health. We know that folks that understand and can read and have higher literacy usually have better health outcomes. And so wanting to start early and give kids that strong foundation led me to do more work, not just with Reach Out and Read, but thinking about early childhood and how to work with schools, how to work with childcare centers, how to work with parents to understand the opportunity to help give kids the best start possible. And then from there, that led me to understand, like, if folks don't have access to health insurance, they don't get those checkups in the first place. They're not going to get access to Reach Out and Read. And that really kind of opened my eyes to the impact of policy. And then one, incident that really, I think was crucial in this for me, it was reflecting after the murder of Philando Castile. And for folks who might not remember, Philando Castile was a Black man who was right around my age, who got murdered by the police, a couple miles from actually where I asked my now father-in-law for his blessing to, propose to my wife. And so it was, a real personal kind of close incident to me to kind of see that and how that was broadcast, and think about how in healthcare we don't have as many like split-second decisions that end up taking people away from their families like the police do, but we have lots of small ones, right, over time, where we deny people care, we don't give them the best care that they deserve, and that ends up impacting their health, that ends up taking them from their family. And we see that happen with our Black, our Indigenous, other communities of color more often than not. And so really wanting to learn more about what I could do to help educate myself and others. And that's what ultimately led me to this kind of diagnosis that one of the things that drives a lot of the inequity is capitalism in our healthcare system. And so really wanting to learn more about policy. And so I came into the role really ready and eager to learn from, my colleagues, but also then to help teach what I knew about how racism and structural inequity showed up, and what I'd learned from the communities I grew up in, the communities I live in, worship in, play in, to share that with my policymaker colleagues so that we could do a better job of making policies that help address some of these long-standing gaps in care.
Okay. Ms. B, question from you.
Wow. Nathan, as somebody who's in the nonprofit world, and deal with social justice, it was kind of refreshing to hear you throw a lot of the terminology that I use on a daily basis, working in health equity, social determinant health, even dealing with current projects, right? Environmental studies, health impact assessments, and understanding, the various inequities, and being a Black woman, honestly, myself here, in America, and understanding how we are disproportionately impacted by the medical system. But I'm going to dive right into Medicaid and the state of Medicaid right now. I mean, take us through some of the tension and, the conversations that have led to some of the decision making at the state level around this program, and what could folks and what have you been able to do just up to what the recent decisions?
Yeah, so I always find it helpful to just do a little bit of like 101 at the top, because healthcare is complex in this country, right? And so Medicaid is different than Medicare, right? Right. And so Medicare gets a lot of attention because it's our program for our elders. And so to be eligible, you essentially have to be a resident or citizen that's 65 or older. And that's it. You're then eligible for Medicare, and the federal government pays for not everything, but a lot of your healthcare costs, being eligible for Medicare. So you asked about Medicaid, and that is the program that I work for. Medicaid is for, it was designed for folks who are poor, low income, don't have access to affordable health insurance. And it's a state and federal program. And so the state puts up $1 and the federal government puts up $1. Generally, like in a very kind of simplistic way. It gets a lot more complicated than that in other ways, but generally it's both the state putting in money and the federal government putting in money. The federal government comes up with some rules of kind of basic types of care and who's eligible for that, and then the states get to kind of also determine rules for who's eligible, and then also determine some of the rules of what are the different benefits that they offer and how much do they pay providers to take care of their community members who are on Medicaid. And so within that, Minnesota has actually been one of the kind of more, creative and, progressive is a word that's used about how we've used our Medicaid program to try to cover more people. And so a lot of folks might also be familiar with Obamacare or the ACA, the Affordable Care Act that, was passed in 2010 and has been implemented here in the state since 2014. But Minnesota actually already had a form of the Affordable Care Act in place in the 90s called MinnesotaCare. And that was really intended to say, instead of just looking at the federal government's rates of who's eligible based off of how much money they make or their family makes, there still was a gap. We see that people were eligible for Medicaid based off of not making enough money, but people who would miss out. They would be making just too much to be eligible for Medicaid, but they didn't get insurance from their employer, and they couldn't afford insurance on like the open market, just out of their own pocket. And so the state came up with a plan to try to give folks more accessible coverage by, helping pay for it with state dollars. And so the Affordable Care Act came through and was able to, expand a lot of coverage, and then the state was able to kind of provide even more coverage because the federal government was now doing and helping pay for what the state was paying for by itself previously. And so that kind of is a very kind of high level overview of where we're at today in discussing, that the fact that the federal government over the last 15 years has really committed more funding to helping folks access coverage. And now the bills that the federal government are considering, the one that was just passed out of the House last week, is looking to really change that relationship and take away some of that funding, make it harder for people to stay enrolled, and therefore the hope is that they will fall off, lose their insurance, and the state and the federal government is their primary goal, won't have to pay as much money for their care. And so that's what we're seeing. They've put forth policies to make it harder for folks who are covered under the Affordable Care Act by making them have to report working requirements. So basically have to report that they're doing some type of work or community service 80 hours a month, every month. And what we know is that will have people that are on health insurance who are already working but are just busy or don't understand the paperwork process. They're going to lose their healthcare coverage as a result. It's not going to go after the very small number of people that might be on the coverage and not be working. It's going to impact a lot of folks who are working. And we know it's going to cost the state more money, as well, to administer it, to do all these frequent checks and to set up systems for folks to have to access it. And then they're also, going after other things like taking away funding for any services at Planned Parenthood. And so not just, care for folks seeking reproductive care and abortions, but preventative care and checkups and physicals and those types of visits that you might get at Planned Parenthood. They're taking away coverage from that. They're looking to give less money overall to any states that are providing care or coverage for our undocumented neighbors. And so taking away 10% of the federal government's share of what they're supposed to give for any states that are providing coverage to undocumented citizens in any way. And so, and we know that overall, like these types of policies, they don't actually improve health. At the end of the day, they're not going to end up saving much money at all. Certainly not long term. You might get some small short-term savings because people lose coverage and don't then go seek care. But long term, people are still going to need care, and they will not go seek it. They themselves will get sicker, and then they do show up because they lose a job and they're now eligible for care. It's going to cost the state and the federal government more to take care of them and get them back to full health if we're able to do that. And so I think it's a very kind of short term lens and approach to some big questions we have about how to better change our healthcare system, and address things like the cost and things like that. But this is not the way. None of these policies really address any of that, unfortunately.
Okay. Well, folks, tonight we are having a conversation with the medical director of Medicaid in the state of Minnesota. So thank you so much for joining us. You can contribute to the conversation by calling our number 952-594-5154 or putting a comment in the chat. But there's a few questions here from our listeners. First, I will start with this one. I don't know if you answer this one. I mean, is your degree in zoology? Is that what it is? And can you expand on that a little bit?
Yeah, absolutely. Good eye. So yeah, I did my undergraduate in Miami University in Ohio,
Okay.
and I went there because they had a very strong pre-med program, and because I wanted to leave Minnesota for a little bit, to be honest. But they did not have a biology program. So you either did zoology or microbiology. And I ended up wanting to do zoology. I was more interested in kind of the physiology of animals. So I have a zoology degree. Tell my two young boys that I could have been a zoologist if this doctor thing didn't work out.
Okay. Okay. Miss Jerry, welcome to the show. Any question for Nathan?
Not at the moment. I'm just gonna keep listening since I just joined, trying to
Okay.
catch up.
Okay, no problem. There's another one here from from a listener. I mean, there is. I can just summarize this, rephrase it a little bit. So, right, with everything that you mentioned earlier, right, from the federal government that's going on, right, a lot of confusion, misleading information, right. But where can communities of color, particularly immigrant families, turn for credible, up-to-date information about Medicaid and related services? And what are two key policy or system changes they should be keeping an eye on right now if they are currently enrolled or trying to navigate eligibility? Can you address this?
Yeah, so I think there's kind of depending on how deep into the weeds you want to get. There's a number of different places. I think Sahan Journal, here in Minnesota, I think does a lot of good reporting on a lot of the policy changes through the lens of our immigrant communities. And so I think that's a good place to kind of stay and see what they're reporting on and who they're talking to. Our website within DHS, where we're trying to keep people up to date and give folks context about the potential impacts of some of these changes, is called Medicaid Matters. And so it's mn.gov, so mn.gov/DHS/Medicaid -matters. And so there you can see a lot of like we have a communications toolkit. So if you are someone who's connected to different organizations, or even something you could share within your place of worship or community centers or other groups about who is impacted by Medicaid currently in Minnesota, and then there's a breakdown that we have there of this current budget reconciliation bill that Congress has passed and what are those potential impacts. And then I think, if you're really interested in getting more details, a deeper analysis, if you're interested particularly in your kind of professional work of following along, Kaiser Family Foundation, KFF, they have really good, and they break it down. They usually use charts and graphics in addition to just breaking down who's impacted. They also, what I really like about them, in addition to kind of just trying to explain what's happening, they do surveys of people to get the sense of folks around the country of what they think about some of these changes. And so like one example is when I was talking about work requirements and how we know they don't work. The reason they keep coming back is because people have been sold this story that there's people on Medicaid that don't work, and so we need to get them off and that save that money for people who really need it, right? And that's a narrative that's out there of why this policy should help. And so they've asked people, like, what do you think about work requirements? And if they ask them just that, like 60% or so think, yeah, that's something that we should do. But when they explain that we have really good, solid evidence that these requirements don't work, that people who actually deserve coverage are going to lose coverage, that's going to cost states money, when they take just another 30 seconds to explain that, then
Okay.
that number flips. And like 70% of people aren't supportive of work requirements, right? And so I think they do a good job of trying to kind of get a pulse, as well as then give you an idea of like what are some of those messages you might find as you're having these conversations in community, and how can you be prepared to kind of like educate and inform folks who really probably share the same goals and
Sure.
ideals as you, but just need a little bit more information to understand the real impacts here.
Okay. Another one here quick, and then we'll get back in the studio, right? If the protection you talk about, Elder, if they are taken away, right? And if they still lose the money, how would they still make up for it? Is there any plans, right? Does the state of Minnesota has any plan right now to make up for the lost revenue or the lost money from the federal government?
Well, some of that's still being debated because our state's still in the process of setting our budget for this year, particularly when it comes to our Health and Human Services budget. And so some of that would have to likely end up cutting some things. If we don't have that amount of federal matching money, then the consideration that we have basically kind of 4 different levers. We increase taxes to cover the same amount of people and the same benefits by generating more state revenue through taxes. We start to decrease who can access it, so there's less people who can access it. Or we keep it the same number of people, but we decrease the benefits. And so maybe some things that we can access now, like dental care or vision care or physical therapy, those things become harder, or less people within the benefit can access it. Or we pay providers less, right? Because we have less money to cover the care, but then that could take away, like folks are already paid much lower for Medicaid than they are for commercial insurance or for Medicare even. And so providers who take care of a lot of our patients would be really struggling to keep the lights on, and they might have to make a hard decision to close. And then everyone in the community loses access to that provider, right? Not just the folks on Medicaid. And so I think that's the piece that we're also trying to lift up, is that, even if you are not, or no one in your family or your community that is currently on Medicaid, we could all lose access to care and services because this is a hit to the whole healthcare system in Minnesota.
Okay. Ms. B, question from you.
I mean, you touched on a lot of them already. I wanted to know, how are our facilities going to be impacted? As I notice, some of them are already getting rid of certain services in the building, and we could be looking at closures to certain, some of them already, especially the ones that are in urban core neighborhoods. Just wanted to get more clarity and understanding around that piece, because you kind of touched on it a little bit.
Yeah, and certainly, I don't work at the level where I don't know the day-to-day finances of our systems, but what I do know is who in our communities are covered by Medicaid, and which communities are just have more of our community members covered by Medicaid, right? And so when you look just based off of race, ethnicity, looking across the state, roughly about 1 in 4, 1 in 5 folks are covered by Medicaid's 20 to 30%. When you look along the lines of race, ethnicity, for Black Minnesotans, it's around 40%. For American Indian Minnesotans, it's around 40%. When you look at our ages, though, that starts to shift. So for our children, our Black Minnesota children, 60% of our children get their coverage through Medicaid, and 60% of our American Indian children get their coverage through Medicaid, and overall about 40% of our children get their coverage for Medicaid. And so all pediatric providers are really going to be hit, but certainly ones that serve a lot of our community members are going to be hit harder because of the number of folks that they take care of on Medicaid. And when you look across the state, if you're outside of the Twin Cities metro, you're actually more likely to have a family member or community member that's on Medicaid or gets their coverage through Medicaid. And so if you're looking in the Northwest and Southwest and Northeast parts of the state, there are more, by percentage-wise, people who get their healthcare coverage through Medicaid. So that's why we have seen, particularly in states who didn't expand the ACA, we've seen a
Mhm.
lot of rural hospitals, rural clinics close because they didn't get that. If folks don't have insurance, they still show up for care. People will likely take care of them, but then not be able to get that money back. And over time, they have to shut their down, either remove services or shut down. And so I do know that our rural communities, our communities of color, are amongst the highest at risk here of losing services, losing providers. But really, particularly when you talk about kids, it's really all of us. If you have any children in your family or your life, their access to care is going to be threatened. If you're planning on having children at some point in your life, access to care is going to be threatened by these cuts.
Okay. So another question, I know Minnesota, when it comes to healthcare, Minnesota is one of the top, healthcare state when it comes to healthcare. But in terms of Medicaid, where does Minnesota rank, right? In terms of maybe administering Medicaid and things like that, where does Minnesota rank when it comes to Medicaid among the 50 states?
Yeah, that there's not a good ranking because it is so different from state to state, because
Okay.
the states set up a lot of their own rules, how they
Okay.
pay, and for their match, the different types of kind of what we call waivers, or different kind of unique things that we cover, that we
Mhm.
apply for, is different state to state.
Mhm.
And so it's really hard to say that we kind of rank a certain way. I think some of the things that were talked about in those Medicaid matter sheets is talking about some of the national rankings of the health of citizens in a state.
Yeah. Yeah.
And Minnesota typically ranks usually in the top 3 among states when it comes to things like health
Oh, wow.
outcomes.
Okay.
But what we also know, one of the reasons I came to Medicaid to work and improve our outcomes, is because those outcomes are different if you identify as white versus if you identify as Black or American Indian or
Mhm.
Hispanic or Asian in our communities. So we still have these disparities, even though overall as a state we do well. But I think the reason that we have such strong health outcomes is in part, not only, but in part because of a really strong healthcare system, and because we've really invested in the health of our communities from birth until our elders. Throughout the lifespan, you get access to a lot more supports in Minnesota than you might in other states, and so that quality of life that is at threat here with these cuts, because that is the other thing, that if we aren't able to, if the federal government does cut the funding, we could take it from healthcare. We could do all those things I just talked about to our enrollees, or we could say we're going to spend less on schools, or we're going to spend less on roads, or we're going to spend less on transportation services, or our farms. It could be coming down to shifts in budgets that impact us like that, because we would just have less money overall. And so this kind of standard of life that we've worked hard to develop really is at threat here. And I'll just from my own perspective, the frustrating thing is, what's the reason? It's to give tax breaks to wealthy folks, right?
Okay.
We're not going to really accomplish any of these ideas of fraud, waste, and abuse that keep coming up with the policies that have been put forth.
Okay. Many immigrants form the backbone, right, of the healthcare system here in this country. How, all of the changes that's going on in terms of, when it comes to the immigrant experience, how's that going to affect, those that are working in healthcare, and even immigrant entrepreneurs, right? How's the whole changes to Medicaid? How's it going to affect them?
Yeah, thinking about employees, like folks like myself, like my parents, who work, it's going to be harder to some degree, because first of all, our healthcare systems will have less money, and so the ability to attract and retain talent is going to be hard. I know, just even since the pandemic, in my own clinical practice, we've seen a lot of turnover of our nursing staff, of our department assistants, our care coordinators, and that's really impacted our ability to deliver the best care that we want to give as clinicians. And so I think you will see that as a potential impact within your own practice, within your own delivery of care, if you're kind of a frontline worker. Certainly, if you are an entrepreneur, if you're looking at kind of starting a healthcare business, there's going to be less opportunities, right? For instance, if you are looking at doing kind of group home or PCA services or things like that, those are benefits that might get cut, right? Or they might get severely narrowed, or they might pay out less. And so then it's harder, less opportunity for you to, seek your goals through to helping your community as a business provider in the healthcare setting and framework. So those are some real challenges, because we have seen folks in our community be able to help their fellow community members and themselves and their families with these opportunities. But unfortunately, we will likely have less of them if these bills are passed and signed into law.
Okay. Well, folks, tonight we are talking to Dr. Nathan Chomilo about, Medicaid. He's the medical director for Medicaid at the state Minnesota Department of Health. So you can join this conversation by calling our number 952-594-5154 or putting a comment in the chat. Ms. Jerry, any question from you?
I'm just curious because I'm a provider and I provide services to a lot of waiver clients. And with all of these cuts, I'm just worried, how will these clients get affected? Because most of them have struggled with homelessness, and we don't want them going back to being homeless. So I'm just wondering, how will these changes and cuts affect their services?
Yeah, so right now, the kind of waiver, most of the waivered services aren't up for like immediate review, but all waivered services, the reason they're called waivers is because that is one of the unique things about Medicaid. The states can apply for a waiver from the federal government to provide care in a way that isn't laid out in the initial Medicaid statute, with the goal of keeping people healthy. And a lot of it is keeping people healthy in their community, right? Instead of having them have to go and be hospitalized or be institutionalized and get a high level of care. It's, can we have services that help support them and are actually, it's better, cost effective, and it's actually better for their physical, mental, spiritual, emotional health, all kind of realms of health. And so those waivers, get reviewed by the federal government on a certain time frame, usually every about 5 years or so. And so with the new federal administration, there's a chance that they'll use that as a way to kind of decrease how much money the federal government has to put into the system and say, yeah, we'll approve this, but we're going to take away X, Y, or Z, or we aren't going to pay for X, Y, or Z. They did put forth in the current bill a clause that requires, and this is going to get kind of wonky fast, but it requires what they call budget neutral policies for some of the waivers. So that means that you really have to kind of verify that like the amount you're spending isn't more than if you had that person institutionalized in a nursing home or some other setting. And so that could impact, some of the waivers and waivered services. The other is a couple months ago, they rescinded guidance that the previous administration had given around what are called health-related social needs. So like housing and nutrition supports and transportation supports. And so that also then might put some of our waivers of that cover housing supports at risk when it's their turn to come up for reevaluation. And we might not have the same types of benefits to help keep folks housed, which then, as you note, puts them at risk for falling into this cycle of being unhoused and all the additional challenges into their health and well-being that come with that. So it's a long, kind of complex answer, but like the short term is that there isn't anything directly at this point, but was certainly something that we are concerned of and keeping a close eye on at this moment.
What are some of the biggest misconceptions about Medicaid? You have been working, with Medicaid now for the last 5-6 years. What are some of the biggest misconceptions? What do people get wrong about Medicaid?
Yeah, I think folks think it's like just a free handout for one, right? And that folks on Medicaid, again, aren't working or aren't, contributing to their communities. A lot of 40% of the folks enrolled in our Medicaid program are children. right?
Mm.
And then when you add the parents of the children, you're already at about almost 60% of our folks are either the children or parents of children, so caregivers. We take care of a lot of folks who are navigating disabilities. We take care of a lot of our elders in the community, right? And so it really is a program that helps take care of each other and our community members. And then I would say kind of another big misconception is just not understanding all the things that you do actually have access to, once you get Medicaid. I think that's one of the things that I'm trying to help us do better at the state is understand all the different kind of benefits that folks have access to. For example, Minnesota was the second state to cover doulas and has actually had a benefit to cover doulas for birthing persons since 2016, but it hasn't been utilized much because the word isn't out there. A couple years ago, we passed a change so that there isn't any cost sharing, meaning you don't have copays anymore when you go to the doctor or when you do a telehealth visit. And a lot of folks don't seek care because they don't even want to pay, like a 10 or 15 buck copay because of all the things they're navigating. But that was something that we changed to try to help increase access. But again, we haven't done as great of a job talking about all the different ways that Medicaid can really kind of help folks and be a bridge. And then if you're in a health plan, so like you get your health care through Blue Cross Blue Shield or Health Partners, Hennepin Health, Medica, UCare, one of those, they're there to serve you, right? They're there to really help navigate your needs. And so I think folks don't always understand or know like the ways that they could reach out to their health plan to help them kind of navigate or find out, like a lot of, for example, going back to kids, a lot of health plans give folks access to things like car seats, right? Because they know the benefit to the family to have a car seat. And so I think there's just a lot of work we have to do to kind of let folks know the full breadth of it, and as well as then to kind of let folks know that money spent on Medicaid is a good investment for all of our communities.
Okay. I know that this is one of the issues that have been in the news a lot, with immigration, with ICE and things like that, undocumented immigrants. I know you mentioned earlier how, the federal government is going to take away funding, for ensuring undocumented immigrants. Right? How's that going to affect the hospitals, especially, and things like that? I mean, and like emergency room, how's that going to, what impact, are those policies going to have on them?
Yeah, there's kind of two things here, right? So the question there was more about, I think, can folks get access to care if they're undocumented? And we still have laws in this country where if you show up for emergency care, they have to take care of you, right? Okay. Now, I think certainly I can't sit here and guarantee, because of the way ICE has been moving, that they wouldn't try to engage someone in hospital settings, because unfortunately we've seen them start to do that. But I feel like it's our job to say, like, if you need that care, and that's like the life pressing thing, then, that care will be provided to you in an emergency setting.
Okay.
So the second piece, though, is like the kind of trickier one, right, about coverage, right, that you were asking about, like, will folks still get coverage? And certainly right now in Minnesota, as of January of this year, we provided our undocumented neighbors access to MinnesotaCare, so a form of healthcare insurance that the state helps pay for. And folks can still sign up through that and get coverage through the end of the year at least. We are waiting to kind of see what comes out of the state's budget negotiations, if that's something that will continue. Certainly, the federal government's decision to cut 10% of its funding to any state that covers undocumented citizens makes that even harder to kind of navigate. And so that's care that, makes a lot of sense because it's preventative care. It's keeping folks healthy, again, instead of waiting until they get so sick that they show up in the emergency room, where we, again, have to take care of them and should be taking care of them, but it costs more money than, to us all as a result. And things like emergency Medicaid, which is a little bit different for folks who are facing kind of need a life-saving surgery, or are on certain conditions like kidney failure. They're on dialysis. They need that dialysis every week to save their life. Those things will continue to be covered at this point, but certainly those are some of the things we're watching closely to see if the federal government changes some of their stances on that as well.
Okay. Ms. B, question from you?
I think he kind of answered my question, because I wanted to make sure about undocumented folks. And you're saying, as of right now, the state hasn't taken a position to say, hey, due to the federals removing 10%, we are no longer going to serve undocumented folks going forward in our medical system?
So there's no bill that's been passed or signed yet. If you read the news, you'll know that the legislative leaders and Governor Walz did agree on a budget framework that to concede to the GOP representatives in the House in particular, would remove our current coverage of undocumented adults starting at the end of this year. So leave coverage for undocumented children, but remove coverage for undocumented adults. But that's still being debated. And so we will have to wait and see what ultimately the legislators and governor decide. But so as of right now, yes, that's not been taken, but certainly is in the conversations that are happening in St. Paul.
Okay. Ms. Jerry, question from you?
Okay, so this is just my personal experience. At some point, I was on Medicaid because I was in college and I didn't have any income. And once I started to have an income, it was almost impossible to get qualified. It's like I needed to make little to no income to qualify. And then I was referred to the marketplace. And even when I was referred to the marketplace, there were so many insurance to navigate. And when I called this insurance company, they told me I had to hire somebody to help me decide what's the best insurance for me. So I was just confused about that whole process. And then the premiums too were so high. So how do we simplify this process, especially for some business owners who might not have insurance to a job that needs insurance for their family?
Yeah. Great question. And your experience is one that I've heard a lot. I've helped my own family members at different times in their lives navigate similar, situations, moving from being uninsured onto Medicaid or MinnesotaCare. And so one thing that I think everyone could use is looking up our MNSURE, MNsure navigators. And so these are folks who the state has some grant funding. There is some federal funding currently to help navigators, and their job is to help you navigate your options for insurance, and whether you qualify for Medicaid or medical assistance, as we call it here in Minnesota, whether you qualify for MinnesotaCare or the Affordable Care Act premiums or subsidies that you're talking about, or if none of those, how do you get a potential plan on the open marketplace? And so they and you don't have to pay them. They again get through grants and through their success in helping folks navigate the process, get paid. And they're all across the state as well. There's ones from different cultural communities, speak different languages, and so the MNsure, MNSURE navigators, if folks just kind of Google that, you can find links to find a MNsure navigator near you.
Okay.
But I think what you're touching on is part of kind of taking off the state official hat and saying my ultimate diagnosis that healthcare should be a right, and that there's so many other countries around the world with less resources than we have here that have figured out a way to get at the very least basic coverage to everyone, no matter what they are making as far as money. If you think about it, there's so many people that might be staying in a job or a certain situation just because that's how they access healthcare. But if they
Okay.
didn't have to stay in that job or situation, they could start their own business. They could help their community other ways. They could be healthier and feel safer themselves, if they were able to not be kind of tethered to their job or a certain situation to get health care. So I think that, ultimately is the work, I hope to kind of contribute to over the course of my life and career, is how do we kind of move the narrative to, this is something that we have enough resources for. We just need to, allocate them better, and that it shouldn't be, you have to jump through all these hoops and spend all this time. We have to pay people to navigate a system. Why don't we make the system less racist, less obstructive, and instead then be able to use those resources on, actually helping people stay healthy or get healthy.
Yeah, like in the state of Minnesota, how does one sign up for Medicaid? I mean, how does the process work, right? From start to end, how does the process work? I know you mentioned like 60% of, case of color are on Medicaid. How does it work? If I want to sign up for Medicaid, how do I sign up?
Yeah, so a lot of times, we say go to MinSure first, because you kind of put their information and they kind of say, based off of your information and how much you make and everything, you are eligible for this type of Medicaid, so medical assistance, or you're eligible for like the MinnesotaCare,
Okay.
or you're eligible for the subsidies. And so that's usually the best or the kind of quickest way to start to get understanding. If you're eligible for Medicaid or medical assistance, the application is still a paper kind of application here in Minnesota that you have to kind of fill out and then send in to your county. Usually there's one sovereign tribe, White Earth, that administers for their members. But otherwise, you're sending it into your county of residence, and then they process it, and then will help determine your eligibility and send you your information from there. And so a lot of folks are usually working with a social worker or a case manager, particularly for their kids when they're going through this process. A lot of folks might show up at the emergency department and have not been seen for a while, and then when you're there, they're like, oh, do you know that you might be eligible for XYZ? And so someone in the emergency department or the hospital helps sign them up, or they're at the county getting other resources, and they say, hey, did you know that as we're helping you get your housing or your assistance, that you could also we could also help you get health care. And so that's the path for a lot of people in our communities.
Okay. If you had like a blank check to transform Medicaid in Minnesota, what will your first priorities be?
I mean, again, I think like everyone, should have access to healthcare. And so one thing we saw during the pandemic, right, when COVID hit, we decided as a country, rightfully so, across the ideological spectrum, that like no one should lose their healthcare in the middle of a global pandemic. And so we didn't go and ask people to kind of send their paperwork in every 12 months or every 6 months in the middle of the pandemic. We just said, we're going to keep your coverage going. And that kept going for 3 years, right? And so, I think we're going to learn a lot about the benefits of having that continuous coverage. And I really think if at any point in your life you are deemed eligible for Medicaid, you should just continuously be covered until you find a situation where you no longer need it, and you shouldn't have to keep submitting paperwork. And this idea of having to kind of like keep proving, because it has been shown to there's a significant number of people that don't make it through the process just because of the paperwork, not because they're not eligible, and that leads to missed care. It leads to and it even leads to things like medical debt, right? Folks who should have been covered aren't. They get in an accident, they get a big hospital bill, and now they're in debt because they didn't have coverage at the time of that unfortunate accident. And one thing that I've kind of tried to share and help folks reflect on is like we're all kind of one bad day away from needing Medicaid. Whether it is just someone who didn't have coverage and got an accident, or someone who has got a great job, has got a great income, and has a devastating injury, and then needs care for the rest of their life, and eventually will end up needing, home-based care and adaptive equipment and all these other things to be a part of their community and extend their life. They'll likely end up getting some of that through Medicaid, right? So I think, understanding that we're all, connected in that way, like the one thing to do is just once you're on it, and we continue to kind of keep people healthy instead of having to kind of play catch up on the back end and pay those higher costs.
Okay. As a medical doctor, being working on the state government now for the last 5 to 6 years, how do you balance the tension between innovation and the bureaucracy that you find in government, right? I mean, I think I consider you as an innovator because you went to medical school and things like that. Well, how do you balance all of the changes, all of the innovative ideas you want to see versus, like government is so slow or government does things differently?
That's a great question. It's having like-minded folks that you can kind of bounce ideas off, that you can, I spent my first year kind of listening more than I did kind of sharing my ideas and thoughts, because I, learned kind of early in my career when I thought like I was like the smartest guy, I'd show up there and someone's like, oh yeah, we already tried it, we really tried that way. And so it really helps to kind of listen first, understand what's been tried and why it might have worked or why it not have worked. And I think the one thing that, certainly gives me a lot of energy, keeps me in this role, is the ability to be in spaces where I'm listening to community members, what's working, what's not, where we're able to kind of take that and then carry that message to decision makers and leaders. I don't get to, make as many decisions as maybe I'd like. I inform our decision makers is kind of my role, and try to provide them with the best evidence so that they hopefully land at decisions that help folks. But I think that being in that position of being a translator and being able to see all like the ideas and solutions that a lot of them are in communities already. There's the folks that are navigating our systems that know where the bumps are and the flaws are, and like, why don't we just get rid of this? One example from our campaign to have to re-sign folks up once that continuous coverage clause ended during the pandemic was folks just being like, well, why don't you just put like a big blue like badge on the envelope so people, they get lots of mail, right? And like, you might miss your notice that you have to renew your insurance because it just looks like any other letter. So like, why don't you put like a big blue dot on it? And that's how we came up with like the, when you see the blue, it's time to renew kind of message, right? And then working with, community messengers to carry things like that. So I think, yeah, like it can be frustrating because government can move so slow, but you also know that like when there's times of crisis, it's really helpful to have someone who knows the system and knows like how to then package the message and say, hey, this is an opportunity for us to do all these things we wanted to do. And so, being in the space and being ready for those moments. I started January of 2020, so right before COVID hit. And I've already started to think about like, well, if I had been here, like in that position a year earlier, I might've been more prepared to, help folks shift in ways when, that crisis caused folks to be open to thinking differently. And so I think that's what I've seen is there's a cycle of, things move slow, but it's like things move fast because there's a kind of opening for change, and then that kind of shuts down and things move slow a while, and then just being ready for that kind of next upswing.
Okay. Ms. B, question from you?
I don't have a question. Just want to say thank you for that little nugget about folks having MNsure having a navigators to help folks that are business owners, entrepreneurs as well, self-employed folks as well, to be able to get healthcare. We provide some of those services, but just when you think you know it all, you've just provided me another extra nugget tonight. So I appreciate that.
Okay. What advice do you have for young professionals, right, especially immigrants of color who want to follow in your footsteps, right? I know it's like to see folks like you where you are, it's like, sometimes it's hard, right? It's like, so what advice do you have for young folks, especially immigrants professionals, young folks coming up?
Yeah, I mean, I think the thing I tell kids in my practice, particularly as they start entering middle school and and high school is, find things that you are really interested in. And if you're really interested in, or it comes easy to you, you're just like, I understand this right away, then keep digging there and ask your teachers, ask your parents, your grandparents, like, what are some jobs or careers that I could do more of this, right? And I think if that's your goal, along with, hopefully folks who are inspired by me, are inspired by kind of a interest in helping folks, because that certainly is something, again, that I saw in my parents and that inspires me, is how to, be a member of your community that gives back and shares their time and talents in ways, I wouldn't be here if folks didn't really move for change in a number of different ways, both in the African American and the Cameroonian communities. So, thinking about what are things that really animate you and interest you, and then how can you use that to kind of help and give back. And I think then you'll find your calling, you'll land in your place. The one kind of thing is, if you're trying to go after money, medicine really isn't the thing. If you're smart enough to, go through medical school and money is your motivator, then you're probably better off served in going into a number of different fields. Medicine is really a field where it's folks who have a heart of service, have kind of the interest in learning and continual learning, and understand kind of like longer term work and towards longer term goals.
Okay, Miss Jerry, any question from you?
It's not really a question. I just want to say thanks for coming on. And Medicaid is a good program. When I was on it was a huge help to me. However, I would just love for you guys to simplify the marketplace process, because it becomes a lot complicated, especially when somebody would not understand all of the insurance terminology and premiums and all of those other stuff. And also the staff who are working, I feel like they don't know, because when you call, they're confused a lot of the times. Like you said, they have navigators. These are things that staff should know, should be able to point people in these directions when they're called the marketplace or insure, because a lot of the times they don't even know what they're talking about.
Yeah, I mean, you're not going to find any argument about the complexity. And in fact, in the number of different communities I've been, whether they be African American, African immigrant, Hispanic, American Indian, our processes and how complex our processes just to enroll and get coverage in the first place is like the number one issue that folks bring up. And so we continue to do that. One thing I will plug here is that one of my, I guess, accomplishments that I helped kind of, as I said, inform decision makers to make a right decision is we, as of this year, implemented continuous coverage for children from 0 to 6 years. And so at any point, if you are on Medicaid and you give birth, your child is eligible for Medicaid, and then they're covered for 6 years. You don't have to do all that paperwork process for them every year. And so I think that's a really good step. As I said, if I had my kind of magic wand, I would do that, be for everyone from birth to 65 when they're on Medicare. But I think it's one good step in the road to get rid of some of that frustration that you are rightfully lifting up about our process and how complex it is just to kind of navigate what you're eligible for.
What do you hope to be your legacy at the Minnesota Department of Health? What do you hope to be your legacy, especially working with Medicaid?
Yeah, I think my hope is that we really kind of shift how some of these policies decisions are made to our communities, particularly our communities that are most impacted, whether directly receiving the services or most impacted by structural racism and inequity. I think a lot of these decisions get made without any context to the people that they will impact the most. And as I said, I think a lot of the solutions are there in community. And so a lot of the kind of work I've done, the reports that I've helped lead have really started there and started like here. Medicaid isn't going to fix everything, right? We don't have the ability to fix everything that causes all our inequities, but here are the things that we can be accountable to. And when we listen and we sit with our community members, here's what they're lifting up are their priorities. And so that's where we should start and go from there. Because I do believe if we, start with the priorities of our communities, everyone will ultimately, benefit as well. So really, yeah, shifting the work of government to be more community-led, co-created would be, I would be just blessed and amazed if that was the legacy that I left behind.
What keeps you going during tough times as a medical doctor and then working with Medicaid? What keeps you going during tough times? And as a side note of that, right, what do you do during your free times outside of work?
Yeah, I mean, I think what keeps me going is my family, my wife, my two boys, Gene and Chare, who are 2 and 8. My parents and brother and sister-in-law and in-laws across the board. Just blessed to have a lot of them around. And so one of the things I've reflected on in a number of spaces is when I got to this role, I started reading a lot of the reports that the state had put out.
Okay.
And the same health disparities I've been talking about the last 5 years, they documented when I was in like 3rd and 4th and 5th grade, like 30 years ago, right?
Okay.
And so we've known about like the way our systems are set up create these disparities. And so another goal of mine is that like when my boys are in their 30s and 40s, they aren't having to have these same conversations and deal with these same problems. There's other problems that they'll be tackling and hopefully solving, but not these same ones. And so that's like my motivation when things get tough is, thinking about how I want better for my boys and better for all of our children.
Sure.
And thinking that some of the if folks who had given up during times of slavery, during times of Jim Crow, if folks had given up when the Europe was colonizing all of Africa, like we wouldn't be here. Folks had just given up instead of continuing to push back and fight, and they didn't all get to see the better life that was created by their work. And so even though blessed in many ways, I also understand that my hope is that the work I do and leave behind makes it even more of a blessing for generations to come. And then as far as things I like, soccer fan, so somewhat suffering Chelsea fan, and watching Minnesota United, and I guess somewhat suffering Cameroonian soccer fan because they like get our hopes up and then crash them out in the World Cup. And then big comic book fan, X-Men, Black Panther, those things. So I love going to comic book movies, reading comics with my boys. I'm kind of a nerd at heart, play video games still, things like that to relax. So outside spending time with family and friends and a little bit of sports here and there, try to keep it even.
Okay. Well, this has been a great conversation. As I said, this is a 1 hour show, so I will give my two panelists here that last word. Miss Jerry, any question, comment from you, to Dr. Nathan?
No, thanks. I feel like he's answered everything of the questions that I had in mind.
Miss B, anything from you?
Again, thank you so much. Appreciate the work that you're doing as far as addressing social determinant of health and inequities, and continue to push those policy changes that will really benefit all, right? I always say when you push policies for people of color, you're actually pushing policies for everyone. It's a benefit. So thank you.
Okay. And with that, any last word from you, Nathan, to our audience who have been listening to you for the last 1 hour? Any message you want to leave our audience tonight?
Yeah, I mean, I think, we just need to see the humanity in everyone, right? And I think that's at the core of so many of our problems, whether we look at how, we're funding genocides across the world versus how we're defunding lots of our institutions here. It's because we've been led to believe that people who are different than us have some different level of humanity. And so just want to kind of leave folks with that message of see the humanity in all of us, treat everyone like they're your children, because they might one day be someone who helps take care of you and your children. You never know. And just thank you all. Thank you, Jury, Miss B, Abe, for having me on and being able to share this space with y'all. Really appreciate it.
Yeah. Well, with that, folks, that concludes the end of our show tonight. Nathan, thank you so much for taking the opportunity to come and talk to us and talk to our audience. I think you dropped some great gems tonight, so we really, really appreciate it. And we hope you can make this your home, right? Is that we've got Medicaid. A lot of our folks, a lot of people utilize Medicaid. So we hope you can come, on here, right, to educate us about Medicaid and some of the things that are happening at the state level. So thank you so much for joining us tonight. And with that, folks, that concludes the end of our show, and see you all tomorrow. Good night.
Truth's bringing hope to the light. Community strong, we're never alone. Together as one, we've